Imagine a routine hospital admission. A newer nurse scans the patient's home medication list, spots Ozempic, and checks a box. They see a common diabetes or weight loss drug, assume it is benign, and move right on to the primary complaint. I'm Brooke Wallace, and this is the SuperNurse podcast. We help nursing students and grads translate complex pharmacology into real bedside judgment. Before we dive into the risks, make sure you subscribe so you never miss an episode. An expert nurse looks at that same chart and sees more than a background medication. They identify an active clinical variable that will shape how they monitor kidney function, assess abdominal pain, and prepare the patient for anesthesia. This requires a complete mental pivot. You stop categorizing these medications as simple weight loss tools and start treating them specifically as delayed gastric emptying drugs. Failing to make that distinction leaves you completely blind to a massive, predictable chain reaction of systemic complications, turning a standard admission into a potential clinical disaster. These medications execute three core functions. They signal fullness, trigger glucose-dependent insulin, and severely delay stomach emptying. This extended retention timeline nullifies standard preoperative fasting rules. Because the gut is so sluggish, other daily oral medications get trapped, and their absorption becomes highly unpredictable. The result is a terrifying reality for anesthesia. A heavy meal eaten 24 hours ago could remain fully intact in the patient's stomach as they are being rolled into the OR. When the anesthesiologist pushes the paralytic, the patient loses their protective gag reflex. If that trapped food travels backward up the esophagus, it is aspirated straight into the lungs, causing deadly aspiration pneumonitis. Preoperative screening for GLP-1s is a high-stakes intervention that prevents respiratory failure on the operating table. The drug's gastrointestinal effects create what Brooke calls the AKI paradox. Despite being FDA approved to protect the kidneys, the semaglutide molecule carries a black box warning for acute kidney injury. The kidney injury stems from stomach paralysis. Unrelenting nausea, vomiting, and diarrhea lead to a rapid, profound drop in overall blood volume. This fluid deficit tanks blood pressure. When renal perfusion drops off a cliff, it starves the kidney tissue of oxygen, causing ischemic damage. The digestive accessory organs are also at risk. When the body loses weight rapidly, the liver compensates by dumping excessive amounts of cholesterol into the bile. Normally, the gallbladder empties that bile out, but the gut paralysis prevents it from contracting regularly. That super concentrated bile sits stagnant until it hardens into sludge and gallstones. As a nurse, you must investigate the pain. Don't write it off as routine nausea. Look for sharp colicky pain in the right upper quadrant or unrelenting pain that radiates straight through to the back, which is a hallmark of pancreatitis. Connecting these dots allows you to identify hypokalemia before the kidneys fail and to distinguish routine nausea from the early signs of organ inflammation. There is also a silent, hidden danger of rapid weight loss that hits older adults. Sarcopenia. Because the appetite suppression is so intense, the patient often stops eating enough protein. Deprived of fuel, the body breaks down its own skeletal muscle just to survive, leading to a dangerous functional decline. Your discharge education must be aggressive. These patients need targeted protein supplements and specific resistance training to maintain their strength and prevent devastating falls. Then there is the common real-world question. Can I have a few drinks while I'm on this medication? Alcohol changes the drug's behavior. It shuts off the liver's ability to release backup glucose, causing a severe symptomatic blood sugar crash, while simultaneously irritating a stomach that is already paralyzed and sensitized. Discharging a patient without specific warnings about muscle loss and alcohol interactions turns a therapeutic tool into a catalyst for physical frailty. Finally, verify their administration technique. This is a once-weekly injection that requires rotating sites between stomach, thigh, and upper arm. Failing to rotate sites causes lipohypertrophy. This is a buildup of hardened, abnormal fat tissue that blocks the drug from absorbing properly, making it ineffective. Patients also storage rules. Unopened pens must stay in the refrigerator, but once a pen is used for the first time, it can survive at room temperature for up to 56 days. But you must warn them, never freeze it. Freezing temperatures irreversibly shatter the medication's fragile peptide protein structure. Even if it thaws, the drug is completely useless. Mastering these specifics, from identifying surgical airway risks to teaching proper storage, is what separates a task-oriented nurse from a clinical expert. For more resources to help you thrive at the bedside, visit SuperNurse.ai.